Welcome to Part 2 of the Mayer Institute's presentation on benzodiazepines, how bad things happen with good prescriptions. This project is supported by a grant from the Benedum Foundation. If you participated in Part 1 of our program, you will recall that we have already discussed pharmacologic properties of benzos and some principles of good prescribing. Today we will move on into the very important aspect of evaluating your patients for evidence of misuse or excess use. We will also discuss developing some de-prescribing strategies and the formulation of some specific treatment plans for your patients. Let's begin with a couple of cases. First being an 88-year-old lady whom we saw in the geriatrics clinic. She had already been diagnosed with dementia, which we found to be in quite an advanced stage and was probably vascular in origin. This lady had recently been moved in with her daughter from her previous residence out of state. Her medications included diazepam, amlodipine, carvedilol, aspirin, valsartan, furosemide, pravastatin, and sertraline. This particular patient had been taking diazepam for 40 years. Her dose prescribed was 5 milligrams daily, but according to her daughter, she had certain days when she was described as nasty and psychotic, and on those days her daughter would give her up to 4 doses, or 20 milligrams total, of Valium. In the days after the higher diazepam doses, it's no surprise that the patient had what the doctor described as a few good days. During these days she was calm and she appeared to be worn out. The patient had a history of having had a fall in January of 2014, which was about a year prior to our seeing her, that had resulted in a pelvic fracture. Now I'm going to reiterate these cases with just a few particular areas pointed out. This lady was diagnosed with a very advanced dementia. Her medication was diazepam. She had been prescribed this medication for 40 years. And while her dose was supposed to be 5 milligrams daily, in and of itself a high dose, her daughter had been on occasion giving this lady up to 20 milligrams daily of diazepam. It is not surprising that she was worn out on certain days after that, and it is also not surprising that she had suffered a significant fall with a serious injury. Now, a second case. This was a 70-year-old lady who was likewise referred to our cognitive assessment clinic, in her case for some confirmation of her diagnosis of dementia. 2.5 years prior to our seeing her, she had undergone a very extensive surgery which lasted 22 hours by their description for achalasia, and after the surgery she had a severe post-op delirium. A year later, she had developed a fistula and she underwent another surgery, this time one that lasted 15 hours, and she is described as having an even worse post-op delirium. And her cognitive complaints, which may have been present somewhat prior to that, became much more pronounced after the second surgery. She had an evaluation elsewhere, including an MRI that had revealed an old occipital stroke. They were told that this stroke had probably occurred during one of her surgeries. Her primary complaint to us was that she was not able to read well. Clearly, with an occipital stroke, that's no surprise. Her husband complained of additional symptoms, including repetitiveness, a certain loss of her executive function, that she would frequently displace things, and that she seemed to have developed an obsession with certain dead family members. Particularly, she would frequently refer to her brother, who had been murdered 15 years before this. Prior to any of these events, this lady had a history of having a substance abuse disorder. She had taken considerable amounts of hydrocodone and methadone through the years before her first surgery. She had also been on Valium and a variety of other psychiatric meds through the years. Just before we began seeing her, she was visiting a geriatric psychiatrist. This person had been able to get her off her benzo onto Seroquel and Remeron, and that was accomplished just before her first GI surgery. This family left that psychiatrist's practice, and they never saw her again after the first surgery. The husband said that her symptoms became quite severe, and he discovered some what he called leftover Valium from earlier prescriptions, and they received a couple of random, relatively small prescriptions from other providers. And by the time I saw her, he had her back on this medication fairly regularly, though it ultimately was shown that he had misrepresented the amount of Valium that she was taking. He claimed, in what appeared to be a credible plan of his, that palliative care would be the most reasonable course for her, but he couldn't locate a provider for such palliative care, and that's not particularly surprising, as palliative care is not widely available, short of hospice, and this lady was not a hospice candidate. That being the case, he called our office numerous times to try to convince us to continue prescribing the Valium to her. And to recap this case, she had undergone 2 very extensive surgeries in the past 2 to 2.5 years, and both times she had had severe post-op delirium. Additional very important aspects: she had a prior history of substance abuse disorder. She had been able to come off the benzodiazepine, but interestingly, the family left the practice of the physician who had done that for this patient. Interestingly, also, her husband had found some leftover prescriptions. So let's use these cases as a backdrop to discuss the appropriate, proper clinical use of benzodiazepines and their potential misuse. If you look at the labeled indications for 2 of the most common benzodiazepines, diazepam and alprazolam, you will see that they have some varied indications, but most of them harken back to the physiologic effect of this class of medications. I think all of us would agree that the medications have a very clear-cut place, and we seldom are bothered by the use of these medications for certain indications, such as acute ethanol withdrawal, sometimes as a pre-op medication, certainly for seizures or status epilepticus. But the indications that I've highlighted here in the red font are the ones that I'm guessing give you the most trouble in clinical practice. How to properly use these medications for anxiety or panic disorders and for muscle spasm complaints, these are the areas that give us a lot of problems in a clinical practice. Now, the prescribing recommendations are fairly straightforward and are widely accepted. The NICE guidelines, National Institute for Healthcare and Excellence guidelines, include that these medications should be used short-term only, and only when the symptom you plan to treat, be it anxiety, insomnia, etc., only when those symptoms are quite severe or outright disabling to your patient. This guideline recommends using up to 4 weeks treatment for anxiety and up to 2 weeks treatment if you are using these medications for insomnia. Certain other aspects of prescribing particularly now that we are having so many issues with prescription drug abuse. It is incredibly important that you document the indication of for this medication and that you document your dosing regimen in the patient's medical record. Likewise, you need to discuss with the patient that you will clearly plan to review and monitor their treatment. According to your practice requirement, you will have some sort of a controlled substance agreement that the patient will most likely need to sign. Every visit after your initial prescription, you must document the results of the prescription and document any changes you make. And needless to say, we're always going to say use the lowest possible effective dose. Now, particularly for your elderly patients, any of these recommendations would apply to any patient, but especially for elderly patients, the Beers criteria highly recommend that you do not use these medications at all due to a known clear-cut increase in cognitive impairment, delirium, falls, fractures, and motor vehicle accidents. Now, clearly, there are cases where, because of the patient's clinical circumstance, it is not likely that you will be able to avoid the use, at least of short-term benzodiazepines. I certainly write prescriptions for these for my own patients, but you try to avoid them whenever you can, and you try very hard to stick to these guidelines because of what we know can happen to elderly patients if you do not. Now, what you'll find if you look at the statistics is that in spite of these recommendations, sometimes quite contrary to these recommendations, the prevalence of use of these medications is rather high. But what you'll also see is that it's, for some reason, very hard to actually get a handle on how much of these meds are used in the general population. Pick up any paper and you'll probably see some different rate listed. One paper that I read said 7 to 43%. Another said 5 to 32%. Both of those are so broad that they are almost self-defined as not being particularly accurate. The most common estimate is that 9 to 10% of the general population probably has used or currently are using these medications. We became interested in this topic and actually conducted a small local study. We asked our partners really how many of their patients would they estimate had active benzo prescriptions. Their guesses ranged from 3 to 35%, and they averaged about 18.5%. We followed that up with an audit of randomly selected charts and ended up with 96 charts. We determined that 24% of the patients whose charts were audited had active benzodiazepine prescriptions. We found that, which was consistent with previous studies, the elderly patients and the female patients had higher use rates. Now, in terms of de-prescribing, we found something else that's also extremely interesting. Over half of those active benzodiazepine prescriptions had been initially prescribed by another physician, either someone that the patient saw prior to joining our practice, perhaps at an emergency room visit, perhaps after a hospitalization, but those medications were being continued. And this, I think, indicates a certain reluctance to de-prescribe, which we will discuss in more detail in the coming slides. Regarding that issue of prescribing from the hospital, a Canadian study recently showed that when they looked at the records of 400,000 people who were older than 66, who had had no previous benzo prescription prior to a hospitalization, 3.1% of those patients received such a prescription within 7 days of their discharge. Another 7.2% received benzo prescription between 8 days up to 6 months after hospitalization. So clearly hospitalization for persons in the elderly age group would be a risk factor for ending up with a benzo prescription. If you look at how prescribing has changed also, if one looks at what's called kilogram lorazepam equivalents per 100,000 persons, that quantity has gone up from 1.1 kilogram lorazepam equivalent per 100,000 back in 1996 to 3.6 in 2013, more than tripled. So let's be a little bit more specific about defining or describing what constitutes benzodiazepine misuse. Well, first is simply overuse, and you need very much to address this in your initial prescribing agreement. It simply has to be an upfront understanding by the patient that you do not plan to allow them to use more of the medication than you prescribed to begin with. If you discover that your patient is overusing, you need to attempt a fairly rapid taper of that prescription. If you cannot safely do that for whatever reason, then you should refer the patient to someone with experience and qualifications to do the perhaps actual detoxification and certainly tapering of the medication. Another kind of misuse is to share those medications. It is sadly way too common for us to determine that patients have been given medications by other people who had the valid prescriptions. If you recall part 1, we discussed the fact that half the patients who had had car accidents and were determined to have benzos in their system, half of those folks did not have valid personal prescriptions for the medication. So clearly this is a problem. It also needs to be addressed up front. You simply must educate and continue to educate your patients. And if the patient will admit to sharing, rapidly taper. They may not admit to it, and in that case you need to be concerned about whether they have actually stepped over the line into actual diversion of medication. Well, diversion is a felony. Probably sharing a pill once in a while with someone else could be excused, but if some actual plan or something that develops into a regularly practiced activity, that's a felony. There are multiple reporting requirements if you determine that this is the case with your patient, and then it more or less leaves your the area of responsibility, becomes a law enforcement issue. So we promised to talk about both avoiding and de-prescribing benzos. The best avoidance strategy is simply to understand what you're treating. Make a very clear determination of what symptom and what signs in your patient you are looking at which make you think they should be treated. Remember that elderly patients sometimes don't complain at all, and if they do complain, it may be something that proves to be so vague that you can't quite make it out. You'll have to be more of a detective in your care of the patient if this is the case. Next, remember that benzos are not the right choice for most patients with panic disorder, not for PTSD, not for depression, most certainly not for depression, because they are depressive medications. A patient without behavioral issues who has dementia does not need a benzo. Patients who carry a bipolar diagnosis, though I think that diagnosis is overused these days, but if the patient carries that diagnosis, benzos are not the right first choice. Now, occasionally, there will be a situation where panic disorder may respond to certain medications, but by and large that's not your first choice. Panic disorders are best approached with SSRIs, SNRIs, even tricyclics, and most especially with cognitive behavioral therapy. CBT, cognitive behavioral therapy, is actually useful for a number of the disorders which you might otherwise be tempted to treat with a benzo. So always remember that. Now, I'm fully aware that this therapy is not available everywhere and to everyone, but if you can attain it, certainly you should keep it in mind for all these patients. PTSD is generally thought to best respond to SSRIs. Depression, of course, needs specific treatment. If it's very severe, very severe, psychotic level depression, electroconvulsive therapy can be considered, but of course that's a highly specialized treatment. A lot of folks ask about bupropion because it seems to be a fairly safe medication for anxiety. I would say that it's out there, it can be used. Some people have a pretty good response to that medication, but be cautious. It can create anxiety, and if it does create anxiety as a side effect, the case tends to be rather severe. So when you've done your a full assessment and you believe that the patient does have an anxiety disorder which needs treatment, remember that non-pharmacologic therapy is out there. Use that first. Remember, we talked about cognitive behavioral therapy. Also, particularly in patients who may have some dementia, they often have triggers or specific environmental events which will stress them and cause their anxiety. Simply, whenever you can, remove those triggers. If they cannot express their symptoms and they act anxious or agitated, look for something that might be causing pain, because if they can't tell you they're hurting, then probably that will be manifested by anxiety. Evaluate the patient's social support. Maximize it whenever you can, because sometimes anxiety is rooted in loneliness. When the patient is appropriate for other therapies and when they have the availability of that, advise meditation perhaps. Advise some simple exercise. Tai Chi is a wonderful thing. It should be more widely available. And then, push comes to shove, you have tried the non-pharmacologic therapy and the patient still needs treatment for anxiety, then do not fear using benzos appropriately, but use by the guidelines. Short-term use, low-dose use, documentation of why you're using it and what your results have been. Now suppose that you have had to make the choice to prescribe a benzodiazepine, or suppose, as is the case with a couple of my patients that I've presented, they come to you already on a benzodiazepine. Then we go over into the de-prescribing issue. The definition of de-prescribing is a planned, supervised process of dose reduction, ultimately stopping a medication that may be causing harm or may simply no longer be benefiting the patient. De-prescribing is part of good prescribing. You want to back off. If the dose is now too high for the patient, if it's simply no longer needed, don't just leave it on there. That definition comes from this website, dprescribing.org, which is a Canadian network. The Canadian medical system has done a great deal of work in this regard, and this is an excellent resource. Why don't we de-prescribe more often and more efficiently than we do? Well, there are certain barriers. There's a very good article in the Medical Journal of Australia from a few years ago which outlines 5 potential barriers to de-prescribing. This is worthy of an entire hour's presentation of itself. So we're going to concentrate on just these two issues in the course of this presentation because they're the most relevant to the particular class of drugs that we're talking about. A reluctance to discontinue meds because of fear of sequelae, and then an uncertainty about the best strategies to do that. Let's talk about that first one, reluctance to discontinue. I'm guessing we've all been here in clinical practice. And why is that? Well, one thing you got to recall is that we or someone started this medication for your patient and kind of sold them on the potential benefit. So if the medication was needed then, sometimes you have to do a job of convincing your patient about why it's not needed now. We've all heard this, haven't we? This medication was started by Dr. Blank. He took care of all of us for 50 years before he died. We trusted Dr. Blank. We loved him. And if he said we needed it, we need it. How about this one? Many of you who will be listening to this presentation are in community practice, in family practice, family medicine, general internists. And you will frequently hear that something was started by a specialist. And if it's started by a specialist, who are you to change that medication? And then finally, the thing that you hear most often by far is, I had a neighbor, I had a cousin, I saw a person on Facebook, and that person had a stroke, or they went crazy, or they died when they stopped some particular medication. Maybe it was Coumadin, maybe it was Xanax. So we have to be aware that patients are listening to other people who may have zero medical expertise, but whom they listen to. And when that person says you can't even consider stopping that Coumadin because you'll have a stroke, then we have to deal with that. Second biggest issue in regards to de-prescribing benzos is that we don't have a good feel for what strategy might work. I think it's important that, first of all, you communicate your thinking to the patient. Sometimes there are even pressures on you. All of you have received those pharmacy benefit manager reports or some message from the pharmacy that certain medication won't be covered. And the patient can't get but a certain amount in a given time frame. So there are pressures on you and your prescribing habits. Patients need to understand that. You need, perhaps as a first step or a second step, to assure the patient that you're not going to make rapid changes. They really fear that maybe you're going to try to stop cold turkey or something close to that. So tell them up front you won't be doing that. Offer them some educational resources, and I think a particularly useful strategy is to have iPads in your office with certain videos installed that the patient can watch while they wait in the waiting room or after you've had a discussion about what you plan to do. You can refer your patients to resources on YouTube, and needless to say, if you do that, you need to verify ahead of time that the resource is saying what you think it's saying. Sometimes I have tapered medications which would not physiologically require tapering, but which, again, it helps the patient to understand that you're not doing a cold turkey stop. So feel free to taper a medication. And then there's some specific strategies out there for benzos, which we'll discuss in the next couple of slides. This is a page which comes from that dprescribing.org resource that I told you about before, and I'm not going to review every word of this, but I do use it to show you what a comprehensive site this is. You can get information about just about any question you have in this regard. So remember to go to this website and utilize those resources because they're out there. And downloading or printing these is totally free. I am going to quote one specific section of that page that I just showed you regarding engaging your patients and their caregivers. When you launch an attempt to de-prescribe a benzodiazepine, the longer the patient's been on it, the more important this becomes. They simply have to understand the rationale. They must know that there are associated risks. They must know that there's reduced long-term efficacy, because otherwise patients may just assume that this is all a part of what's happened with prescription drug abuse, and you just want them off that medication even though they would never abuse it. But they need to know that for any given patient, regardless of the reason it's being used, there is risk. They also need to know, do not deny to them that some fairly mild withdrawal symptoms may occur. It may be a bit of anxiety, it may be a day or two of insomnia, but for most patients, they are mild, they are transient, short-term effects which are not going to last so long that it outweighs the benefit of stopping the medication. They also need to understand that they are part of the tapering plan. If these symptoms at some dose reduction stage are more than they can tolerate, then they can slow the tapering rate. Needless to say, you need to know that they've done that, but it's okay if they do. In regards to the tapering, you need to go slowly. Now, I'll leave this "go slow" in all caps as an homage to what you hear from a geriatrician just about every lecture: start low and go slow. But of course it is a slow process that you need to undertake with the patient fully aware that this is not going to happen overnight. If your patient's more than 65 years old, your tapering plans should decrease their dosage by no more than 25% of the weekly dose every 2 weeks. Then you get near your taper, you probably want to cut that down even more to maybe 12.5% every 2 weeks. Dose-free days are an option when you're tapering, especially because sometimes the available pill forms do not allow the patient to easily have or quarter their pills. But early in the tapering process, you want to avoid having whole days skipped in the treatment. Here's a tapering scheme suggested by the Empower study, which was one of those Canadian studies I mentioned to you earlier. And you can see how incredibly slow this goes. They start with the patient at dose X, and it takes 21 full weeks before the patient is completely off the medication. So it's quite a short-term, it's quite a long-term process with very small doses towards the end. In this case, first 2 weeks of tapering, this patient only has 1 day in which they take half a dose of medication. This is, by the way, available at dprescribing.org. So in summary, let me give you a follow-up on those 2 cases we presented. The first lady, I don't have a full follow-up because I only saw her twice, I believe, before she was placed in a nursing home. So one hopes the de-prescribing was continued there, but certainly it would have been a huge challenge to de-prescribe a lady taking as much as 20 milligrams of diazepam in a single day had she continued outpatient. Second case, this lady has been lost to follow-up because they couldn't find palliative care, and it's not even clear to me that that's really what the husband and the patient wanted. There were many behaviors which indicated they simply wanted to continue the medication, so it's not clear. They have not come back to see me. The next thing about the summary of what we've presented is that in order to properly use these medications, you need to know about both prescribing and de-prescribing. Develop good habits in those, and you can successfully use these very effective medications. It takes a remarkably good clinical evaluation to get a proper diagnosis, and likewise to do the monitoring that's required for de-prescribing. So it's a critical aspect. It's not that hard. It's not going to add a whole lot to your workday, but it's an important thing that you'll be glad you've done. And remember always that when de-prescribing is your goal, the patient has to be a partner in that. Sometimes even if it's someone you think wouldn't be willing to come off the medication, you prescribe the reason, explain the reason why they should, and then you give them a good, solid de-prescribing process to follow, and success is clearly quite possible. Thank you.